Okay, so back to lingula right here, cardiac notch, and it's very much pronounced when we look at it in this coronal plane, this cardiac notch, this area notched out for the heart to sit right into the left lung. Okay, fissures, there you go. Let's switch over to, I just want to look at a sagittal slice. Here we go. Sagittal slice here. So we can just point out the mediastinal spaces, okay? So superior mediastinum, the posterior mediastinum, and then the, superior mediastinum, inferior mediastinal space, and then anterior, middle, and posterior of the subcompartments in the inferior mediastinal space. So superior, inferior border of the manubrium, draw a line over to T4, which is, let's see here. Oh, sorry. We need to count the vertebrae. So this is 12, 11, 10, 9, 8, 7, 6, 5, 4. This is 4. So remember, we draw this imaginary line from the inferior border of the manubrium over to the inferior border of T4, the superior border, and then T1, 2, 3, 4. This imaginary line, this imaginary line, that's your superior mediastinal compartment, okay? And then everything below that is going to be your inferior. And then now getting to our nice middle slice in the center of the thoracic cavity, we're going to look for our anterior, our middle, and then our posterior mediastinal space. So our anterior is from the posterior chest wall to the anterior pericardium, which is right here. This is the heart here. Anterior pericardium. So this little space in here is the anterior. The middle is basically the heart itself, right? Here's the heart to the posterior pericardium, which is right here. That's your middle mediastinum. And then from the anterior body of the spine to the posterior pericardial area is the posterior mediastinal space, which basically has, for our purposes right now, the aorta, the descending aorta. Okay, so those are your mediastinal compartments. So one thing I just want to show you, we went over all of the anatomy for this week on the normal CT, but now that we're switching over to the traumatic chest, I want to show you just some variations and how once you have a solid foundation, even when you have this traumatic injury, you can start to see the same anatomy. And you're going to, as a seasoned CT tech, you're going to start to see some anatomical changes, and you'll recognize them even more when you have a solid foundation of your anatomy on your normal CTs. So thoracic inlet, T1, first rib right here, following it around, articulating with the manubrium. This is clavicle here, okay? SC joint right there. This is your trachea. This person is intubated, so you can see the ET tube in the trachea. The ET tube placement, you guys should probably know by now, should end approximately 1 inch superior to the carina. So let's scroll down and look at the carina and see if it ends about 1 inch. And it does end above the carina. Remember, these are millimeter slices, so I don't know how many millimeters are in inches. You guys can figure that out. But as you go down each slice, it's a certain amount of millimeters. And then you have your bifurcation, your branching of your right and left main stem bronchi. So I think it's a pretty good placement for your ET tube. Okay, your bronchi here So even though we have a lot of anatomical changes, there's a lot of fluid in the lungs. Look at here, you can see, because there's fluid in the lungs, you can see the two viscera. Okay, we'll probably see them even better on a lung window, which we don't have. But you can see the bronchi here branching secondary, tertiary, all the way down. Okay, carina, again, this is an arterial study, a CTA, so we have a lot of nice white contrast in the arteries in the vessels of the chest. So at the level of the carina, I should start to see my pulmonary arteries, which here they are. There's your main branch right there, coming up out of the heart, branching over to the right lung, and then branching over to the left lung, okay? So any filling defect in here would be a pulmonary embolism. There's your descending aorta, your ascending aorta, there's your arch, and here's the traumatic aortic injury right here. You can see how it's got a notch there, and it's not supposed to have that notch, okay? It's an injury, and this is all probably blood that's filling up the mediastinal space, the posterior mediastinal space, okay? Because the descending aorta lies within the posterior mediastinum of the inferior mediastinal compartment, okay? So there's your traumatic injury there. We can switch over to the coronal and look at this and see. The other thing I want to point out, remember we talked about the thoracic cavity, the bony anatomy, and these piggybacking of the costal cartilage of the lower ribs. This is the piggybacking. These are, see, we have a piggyback here, piggyback coming in here from 12 up. Okay, so here's where they come in, piggyback in and attach, and I always love looking at this image because it's so detailed. You'll never see a sternum look like this on any other modality. Look at this. So there's your sternum with your costal cartilage coming in and attaching right at your sternum. Okay, and you can definitely see these little web finger-like piggybacking costal cartilage coming in and attaching. Okay, so there's this one, anterior, right lung, left lung. Okay, this guy's got trauma, so it's pushing stuff around. You can't quite see. There's your lingula of your left lung, cardiac notch, hilum. Here's your trachea, carina, right here, this notch. Right main stem bronchi, left main stem bronchi, and I want you to see how vertical that is. See how vertical that is? And we took a turn here over to the left in the left main stem. Okay, and then it's going to start branching, secondary, tertiary, all the way out. And then this guy, we'll switch over to this one. Same thing. Look at the fingers, the piggybacking. Okay, this is a bone window, so we're just going to see a lot of bony stuff here. But we should be able to see the same stuff. We're not quite seeing the lingula anteriorly because there's fluid in here. And you can see it's collapsed. So we have a collapsed lung on this side. The left lung is collapsed. So right along the edge of this lung is your visceral pleura. Your parietal is going to lie all on the outside. There's fluid in here. You can see this fluid. Okay. You can see our horizontal fissure of our right lung, our oblique fissure of our right lung. We're not seeing any fissures of the left because it's partially collapsed. Although you can see in here a fissure filled with fluid posteriorly. Anteriorly, it's collapsed. Okay. Let's see what else. Let's switch over to the axial. Same thing, intubated. This is the esophagus, which we'll go over next week. And then when we get into the neck, esophagus is always going to be posterior to the trachea. Trachea you should never have any problem seeing. The esophagus you will have a tough time seeing because it should normally be collapsed on itself. The only time you will see it is if it's filled with some kind of something that's going to visualize it, that's expanding it, whether it's contrast, air, water, gas, if you do gas bubbles. In this instance, it's filled with air, probably because of the trauma. And I imagine this person is probably recently intubated, that there's probably air in the stomach that's coming up, and yeah, see all this air in the stomach, and it's expanding the esophagus. So trachea here, first branch coming off, right, left, and look at, here's your pulmonary arteries, main branch, right and left. Okay, so carina is really important to say. All right, so I hope that helps you guys this week. Anything that we've gone over here is fair game for a test. And we'll go over these probably some more in more detail next week when we move on.